Hello everyone, today we are from HDP2 are going to talk about a student project with the topic from immune system and disorders, blood group incompatibility in newborn. Next slide. Here are the lists of our group members from HDP2. Next slide. Chapter 1, Introduction. Next slide.
Hello, my name is Nikita Omni Kanya Uttami, and my student number is 048, and I'll tell you about the background of this new project. Blood group is an inheritance character of red cell surface detected by specific autoantibodies. The two most well-known blood groups are the ABO system and Rhesus system. The ABO system classifying blood group into four blood types, that is type A, B, AB, and O, based on the presence or absence of this antigen on the red blood cells. Meanwhile, the Rhesus system classifies blood groups into two primary types, that is Rhesus positive and Rhesus negative, based on the presence or absence of Rhesus T antigen on the red blood cells. Blood group incompatibility is a condition when the individual's blood group doesn't match that usually occurs in blood transfusion or during pregnancy. ABO incompatibility is an inherent incompatibility between the blood types of the mother and the fetus. When the red blood cells between mother and the children are incompatible, it can cause hemolytic disease that leads to morbidity and mortality. Our knowledge of blood type incompatibility has grown over time, improving prenatal treatment and the prognosis for afflicted newborns. Research on this issue is still ongoing, which improves our understanding and help prevent and cure it. Therefore, in order to better understand blood type incompatibility disorders, we'll go deeper into definition, epidemiology, pathophysiology, diagnosis, prevention, and management in the study.
Hello everyone and doctor, my name is Amelia Sasikirana Dewi with last 3 digit 207. Today I will explain about the problem formulation of this paper. The first one is, what is the definition of blood group incompatibility? What is the epidemiology? And what is the pathophysiology? What are the symptoms and complications? What are the diagnosis and differential diagnosis? And how to prevent and manage this disease? Next, I will explain about the objective. The first one is to inform about the definition of blood group incompatibility. Also, to inform the epidemiology, the pathophysiology, to inform about the symptoms and complications, also the diagnosis and differential diagnosis, and to inform about prevention and how to manage this disease. Next, I will explain about the benefits. The first one is theoretical benefits. This paper can be used as the source of information to know about the blood group incompatibility, the epidemiology, pathophysiology, symptoms and complications of blood group incompatibility, the diagnosis, differential diagnosis, and how to prevent and treatment of blood group incompatibility. The second one is practical benefit. This paper can be used as a reference regarding blood group incompatibility, besides to increase experience and widen knowledge to writers in writing scientific literature. That's all from me, thank you.
Chapter 2, Literature Review. Next slide.
Hi, my name is Skylenn Hertanto Tan with the last three digits of my student number is 145, and I will continue to explain about the definition of the blood group incompatibility in newborns. So what is it? A blood group incompatibility in newborns is a complex and potentially life-threatening condition that arises when there is a great disparity between the blood types of a mother and her newborn infant. This condition manifests when the mother's bloodstream contains antibodies that have the capacity to recognize and attack the red blood cells of the infant, primarily due to variations in blood group antigens, such as the ABO or Rhd blood groups, leading to a potentially serious medical condition. The most prevalent form of blood group incompatibility occurs when the mother possesses an Rh negative blood type while her body is an Rh positive. In such instance, if the mother's immune system generates antibodies targeting the Rh antigen present in the baby's red blood cells, these antibodies can traverse the placenta and initiate hemolysis, which is the breakdown of the baby's red blood cells, and this hemolysis can result in severe anemia, jaundice, and other associated complications, which, if left unaddressed, can progress to more critical issues, including brain damage or the worst case scenario, even infant mortality. Maybe that's all from me. The next slide will be explained by my friend. Thank you.
Hello everyone, my name is Julyvia Gifensius with last three digits of my student ID number are 212. So epidemiology. Neonatal hemolytic illness affecting 50% of babies often occurs during the first pregnancy due to ABO incompatibility. The condition affects about 15 to 20% of all maternal or fetal couples, but only affects 1% of group 0 women with high immunoglobulin G and PA or B antibodies. Significant hemolysis is only 1% of the time linking with ABO incompatible newborns. Versus incompatibility prevalence varies by race and ethnicity, with Rh negative individuals comprising 15% of white population. Rh positive heterozygous men have 85% chance of mating Rh negative women, increasing SGFN with FMH occurrence. Fetal blood alloimmunization requires only 0.1 milliliter with only 1 to 2% of Rh alloimmunization caused by antepartum FMH. SDFM should be considered at all pregnancy tests where FMH is possible. That's all from me. Thank you.
My name is Dian and my last digit of my student ID is 017. I'll continue with the pathophysiology. So the first one is ABO incompatibility. Anti-A and anti-B antibodies of the mother will cross the placenta and bind to the red blood cells. This will activate the complement cascading effect and lyse the red blood cells in the fetal circulation. After that, heme catabolism occurs and indirect bilirubin increases. Neonates with A or B blood group with O blood group mother which has anti-A and anti-B antibodies are the one most frequently affected. The next one is rhesus incompatibility. Exposure to rhesus-positive fetal blood will make rhesus-negative mothers produce antibodies against the antigen, or which is known as sensitization. Maternal rhesus immunoglobulin G or IgG antibodies will last forever, and they can cross from the placenta to the fetal circulation. Maternal rhesus immunoglobulin G will form an antigen antibody complex with rhesus-positive fetus red blood cells and lyse them. Sensitization will not affect the first fetus because the fetus is already delivered by the time sensitization occurs. Hemolytic disease of the fetus and newborn may occur during the second rhesus-positive pregnancies. The next presentation will be continued by my friend.
Hello, my name is Bernard with the last digit of my serial number is 103. Now, I will discuss about the symptoms of blood group incompatibility. Anemia is a medical condition that can sometimes be symptoms of blood group incompatibility, especially in the context of hemolytic disease of the newborn, also known as erythroblastosis fetalis. Let's explore the relationships between blood group incompatibility, anemia, and a serious condition known as hydrops fetalis in newborns. The severity of anemia in cases of blood group incompatibility can vary. In mild cases, anemia may improve on its own. However, in more severe cases, serious complications such as hydrophytalis can arise. Hydrophytalis is a serious condition in which abnormal amounts of fluid accumulate in two or more areas of the fetal or newborn body. There are two types of hydrophytalis, immune and non-immune. Immune hydrophytalis is typically associated with a severe form of rhesus incompatibility, where a mother with rhesus-negative blood type develops antibodies against the rhesus-positive blood cells of the baby. This can result in the destruction of a significant number of the baby's red blood cells, leading to issues such as total body swelling. The other one is non-immune hydrops fetalis is much more common and has different cases. It can be caused by fetal heart or lung problems, severe anemia due to conditions like thalassemia or infection, and genetic or developmental issues including Turner syndromes. That's all from me, thank you.
I'm Ngurah, Bagus, Bhismaka, Ariel, Anindya, and Putra, and my last 3-digit numbers are 1 to 4. And now I will discuss about hyperbilirubinemia. Hyperbilirubinemia, a yellow discoloration of skin, eyes, and other body tissues due to excessive bilirubin accumulation in the blood, is a prevalent symptom found in newborns suffering from HDN. It is caused by the immune-mediated hemolysis of erythrocytes, resulting in biliverdin release from heme molecules, which is then converted into bilirubin. Hyperbilirubinemia may further cause neurological dysfunction due to the unconjugated or indirect bilirubin's ability to cross the blood-brain barriers and accumulate in the brains of a newborn. Newborns are at high risk of developing acute bilirubin encephalopathy when serum bilirubin levels are rising rapidly, greater than 8.5 mol per liter per hour, or elevate significantly, greater than 360 mol per liter. It may manifest as abnormal tone, including hypotonia and hypertonia, poor feeding and sucking reflex, lethargy, high-pitched cry, fever, irritability, retrocolis, and opisthotonus. This acute injury will further develop into chronic bilirubin encephalopathy, classically known as Kern icterus. Kern icterus may cause neurodevelopmental impairment and manifest as sensory neural deafness, aphasia, athetoid cerebral palsy, Pernot phenomenon, or paralysis of upward gaze, cognitive and intellectual impairment, and also seizures.
Hello, my name is Matthew Refferty, with the last three digits of my student ID 003. Now, I'm going to talk about the diagnosis of blood group incompatibility. Usually, the diagnosis can be done by just comparing the blood type of the mother and the newborn. But since the incompatibility can lead to hemolytic disease, the diagnosis must be done clinically and with some lab investigation. From the clinical aspect, doctors can do anamnesis and physical examination to the mother and the newborn as well. From the lab investigation, doctors can do complete blood count tests. If hemolytic disease is indicated, doctors may find decrease in hematocrit, hemoglobin, and then increase in LCH and UCB in the newborn. And then from the direct and indirect Coombs test, a positive reaction from the direct test indicates that the IgG is attached to the surface of RBC's newborn. And then a positive reaction in indirect Coombs test indicates that the IgG of the mother is roaming freely in the serum's newborn. And then doctors can do peripheral blood smear tests. From the test, doctors may find abundance of nucleated red blood cells, which indicate hemolytic disease. Then doctors may find sperocyte as well in ABO incompatibility, which indicates that the diagnosis is autoimmune hemolytic disease. And then doctors, in some severe cases, may find schizocyte and Burr cells, which indicates that the newborn is at risk of sepsis. That's all from me. Thank you. Next slide.
Hello, my name is Pururaswini Pururaswini Astawa, and my last three-digit number is 161. The first differential diagnosis is neonatal anemia, characterized by a hemoglobin or hematocrit count that is below average due to a decrease in the number of red blood cells. Number 2 is neonatal jaundice, occurs due to an increase in total serum bilirubin and resulting in red blood cell hemolysis. Number 3 is galactosemia, is a disease in newborns that occurs due to disruption of activity of enzymes that work to help galactose metabolism. Number 4 is thalassemia. The pathogenesis of thalassemia involves problems in the synthesis of alpha or beta chains of hemoglobin. The disruption of this mechanism causes damage to red blood cells and resulting in hemolysis. Number 5 is glucose 6-phosphate dehydrogenase deficiency that caused by a dysfunctional mutation of the glucose 6-phosphate dehydrogenase gene. And this deficiency can also lead to hemolytic anemia and increase the risk of hyperbilirubinemia. Thank you.
Hello, my name is Ana Agusaguranisuma, and the last three digits of my student ID number is 181. I will explain about the prevention of blood group incompatibility. Blood groups are hereditary, which means the newborn's blood group is determined by the genes inherited from the parents, and it is not possible to choose which group the newborn will have. In the case of blood group incompatibility, the best prevention is to check the blood group of the mother before or during pregnancy and prevent maternal sensitization. Identification of the rhesus status will be carried out early in pregnancy, and if the mother is rhesus negative while the fetus is positive, blood group incompatibility can occur. When this condition occurs, the pregnancy care provider will prevent maternal sensitization by injecting rhesus immunoglobulin. After injection, the Mothers should be close monitored to watch for any symptoms of systemic responses such as high fever, hypotension, hemoglobinuria, and respiratory distress. That's all from me. Thank you.
Please help me introduce myself. My name is Julyvia Gifensius with the last three-digit registration number 088. I will now explain about the treatment for blood group incompatibility. Blood group incompatibility, such as rhesus incompatibility, is treated with a mix of preventive and therapeutic treatments. One of the treatments includes ROD immunoglobulin or RHIG, where it is given to rhesus-negative mothers during pregnancy and postpartum to prevent rhesus factor sensitization. Regular prenatal monitoring, including diagnostic testing and ultrasound, assists in determining the severity of fetal anemia. Interventions such as intrauterine blood transfusion or IUT may also be required in severe cases. That's all from me. Thank you.
Chapter 3 Conclusion. Next slide.
Greetings, my name is Putu Sri with last three digits of student ID 201. So the conclusion of this student project is blood group incompatibility is a serious and a potentially fatal condition that occurs when the mother's blood type is significantly different from her newborn's. ABO incompatibility affects 12% of pregnancies. 3% of the newborns show signs of fetal sensitization. RH incompatibility rates vary by race, with 15% of white individuals being RH negative. Incompatibility triggers an immune response. RH incompatibility can lead to hemolysis, while ABO incompatibility destroys the baby's red blood cells. Symptoms vary in severity, including jaundice and anemia. Severe case may lead to the conditions like hemolytic disease of the newborn, hydrops, fetalis, and kernicterus. Diagnosis involves clinical evaluation, medical history, and lab tests. High-resolution ultrasound is used for early detection of fetal hydrops. Early detections and RH immunoglobulin administration are crucial in RH incompatibility case. The best preventions involves testing the mother's blood type before or during pregnancy and administering RH immunoglobulin if necessary. So that's all the conclusion of the student project. Thank you.
This is a list of reference that was used in making this student project. Next slide. Now we have reached the end of the presentation. We hope that the viewers can gain a lot of new insight and knowledge about this presentation. We are sorry if we had said something wrong earlier. Thank you for listening and don't forget to like the video and subscribe.